Good morning. Dr. Bobby, on behalf of New Age Cosmetic White EdTech Healthcare Consultancy, I welcome all of you back to our regular lectures on biology and chemistry. And in the section of biology, we have the subject of cancer, which has to do with cell signaling, communication, cell and the disparities, and various aspects about cell growth and development. So this is about abnormal cell growth, right, which is manifesting as cancer. So based on that, we're on a subject called cancers in children. So to start with, let's listen to a video on beyond treatment, caring for the needs of children with cancer, presented by the NIH, National Institute of Health, and the National Cancer Institute from the United States of America. I use these resources to create general awareness, to teach students, and to help you prepare for the upcoming exams, for the NEET exams, for all the Institute of Medical Sciences, for the Council of Scientific and Industrial Research. I repeat, the Council of Scientific and Industrial Research exams conducted by the National Eligibility Tests in India. So please listen carefully to the videos, make notes, but kindly do not reproduce any part of my lectures or the videos for any commercial purposes. Use it for study purposes, right? And all of my lectures are available for your study, for daily use on YouTube. From henceforth and the past 70, 80 lectures since the month of August, all are available for your references, and all future videos coming up. So here we start with on this present lecture with this concerned video, right? So please listen to the authorities on the subject itself, and who are prominent doctors who are treating children with cancer inconveniences, and they're treating them to have a better life. So here we go ahead with the video.
Direct the Psychosocial Support and Research Program at the National Cancer Institute.
I'm Dr. John Glad. I'm the Clinical Director of the Pediatric Oncology Branch at the NCI.
I'm Stephanie Feinberg. I'm a Resident Services Manager at the Children's Inn at NIH. We are a nonprofit organization located directly across from the NIH Clinical Center that provides housing and services to children and young adults going through treatment at the NIH.
In addition to the three of us, we will also be joined toward the end of this event by a parent who has a patient at the Children's Inn.
In conjunction with the topics that we will be discussing during today's broadcast, we encourage you to ask questions in the comments section of this video. We ask that you keep your questions and comments to today's topic. If we do not get to your question during the event, we will answer them as soon as possible in the comments. As a reminder, we cannot answer your questions about your treatment publicly. Please talk to your physician about these questions directly. Please note that the NCI reserves the right to not post comments and to remove comments that are inconsistent with our policy at our complete discretion. Additionally, if you have further questions, you can contact the National Cancer Institute's Cancer Information Service at 1-800-4-CANCER or by visiting cancer.gov/contact for live chat help. Okay, let's go ahead and get started. Our first topic that we will be discussing today is an overview of what exactly do we mean when we talk about psychosocial aspects of care for these children.
Thank you, Stephanie. The diagnosis of childhood cancer is a life-altering event for the child and for the family. And pediatric oncology treatment goes beyond the medicine and the care that is provided. One has to think about the whole child and the whole family. We think about the child's emotional well-being, psychological well-being, social well-being, spiritual well-being. So psychosocial care encompasses all of that care, and it's critically important throughout the course of the treatment and beyond that we consider that whole child and family and how they cope and how they adapt. And there's excellent data to be able to support each of those, make a difference in the outcome.
I think those points are exactly key of what the Children's Inn does. The Children's Inn, our mission and our goals encompass three overarching themes. First and foremost, we want to make that childhood possible. We want every child, no matter what their illness and their burden is, to be able to feel like a child again and have those experiences of participating in programs and activities here. Second, we want to reduce the burden and the illness on the family themselves. We want our caregivers to feel like they have support amongst staff, amongst each other, participating in experiences to bond with other caregivers, participate in respite events, and last but not least, we want to support the research of the NIH themselves. If children and young adults are willing to come here and are excited to come here, we hope that carries over for them being able to participate in treatment at the clinical center.
Yeah, that's truly psychosocial care. As you know, we often say there's no health without mental health.
Exactly.
And you do provide that.
Exactly.
I know that it's really important for the patients that we bring to the NIH. We ask the patients and the families to go through a lot of really difficult circumstances to participate in the clinical trials. And one of the things that's especially difficult is almost all of our patients are traveling far away from home. They're away from their normal supports services. They're away from their normal family supports. And I think the IN and the psychosocial support at the NIH is really important to allow families to be able to take that giant leap and move away from home to participate in clinical trials.
I think that brings up a good point of why the Inn was created in the first place. Back in 1990, our doors first opened, and Dr. Lori Weiner can attest to this, as she was one of our founders of the Inn, so I'm happy to hear your thoughts as well. But essentially, Dr. Phil Pizzo saw parents staying in the hallways after a day full of treatment or sleeping in their cars, and that's not good support and good for their mental health, as you stated earlier, for their child going through treatment and for the caregivers themselves. So the Children's Inn was created to give them that place to stay. If after a long day they have a place to rest their head. And not only that, but they have food services, so that doesn't have to be a worry. They have support services. They have programs for children to just forget about their whole day at the clinical center and just feel like a kid again.
That's very true. How often the children say, I have to go back to the Children's Inn, and they forget that they're coming up to go up for treatment. And it is because they have that to look forward to that they're much more adherent with their treatments. Absolutely. And they want to be able to come back and more research could be done. More cures can be found.
Absolutely. I tell the same story over and over, but I feel like there's so many kids that come here who are so excited to be at the Children's Inn, and mom and dad will come over to me and say, they didn't even remember that they're here for treatment. They just are so excited to be at the Children's Inn. So thank you for all you did to make the Children's Inn possible.
A lot of people involved.
Wonderful. Go ahead to section 2.
Sure. Let's see if I can work the computer.
Okay, so topic number 2, let's focus more on services that we provide to support children with cancer. So what are those types of services and experiences do you use or we use to provide that support to children with cancer?
So psychosocial support includes many different interventions, again, as I said, from the time of diagnosis through the course of treatment and beyond. So it can be for a young child being able to understand what's happening, and for parents to need some guidance in how to disclose the diagnosis to their child and to the other family members. It could be for the very young child to be able to just process what's happening to their bodies, and to be able to help the parents to be able to parent their child who is now taking medicines that may make them feel sick and having procedures that could be very frightening. We use many different techniques. It could be for a young child, storytelling, therapeutic play, medical play for their preschool and the school-age child. You know, as they get older, we have behavioral interventions. Dr. Glad may refer a patient over to me because he needs them to be able to swallow a pill to participate in a clinical trial, or was too afraid to be able to get their blood drawn, so we're not able to be able to start the medication. And we would use different techniques to be able to help them to be able to cope with that. It could be for the school-age child who wants to go back to school but is afraid because people will tease him or her because they don't have hair, or to deal with more body image issues, especially for the teenagers, from anything from hair loss, weight gain or loss, to amputation. And for adolescents, helping them really start to participate in decision-making and adherence to treatment, a sense of ownership. For those who survive, many other issues come up, to be able to get reintegrated and to be able to learn about self-care, transition to adult care. And for those who aren't going to survive, to be able to help them, to be able to process that, to be able to do legacy work, to be remembered, to be able to communicate this with their families and help their families communicate with them, and to be able to help the whole family member through that process. So it's a process throughout the whole trajectory.
That's great.
I know when we have patients who come to the clinical center, we want them to be as comfortable as possible, and the IN and the psychosocial support service can really help with that. But it's also very important to have the child, no matter what their development and no matter what their age, to understand to the best of their ability what's going on, what sort of procedures they'll be subjected to, what for the older kids, what is a clinical trial, and what are the ramifications of participating in a clinical trial. And we use some of these psychosocial support services to try to help with that, from Dr. Wiener's group to the school teacher to the child life services. They can incorporate play and school and other discussion with someone outside the immediate medical team into trying to understand what's going on.
So psychosocial care is integrated into every aspect of care. There's not medical care and then psychosocial care. It's all together. You can't think of a child just in terms of the medication that they need to take or a disease. You need to think of them in the
The exam now is 6 o'clock, Indian Standard Time.
context of their emotional, psychological, social, and it said spiritual well-being.
Absolutely. The Children's Inn offers different types of programming. We have educational programming, recreational programming, and therapeutic. Falling in the therapeutic program is actually our most popular staff member, Zilly. She is our therapy dog. One of my favorite stories of Zilly, actually hearing both of your conversations of working with these patients. One of our patients had these very painful injections, and every time he had those painful injections, he asked that Zilly sit with him to support him and get him through those injections, and he did. And so their family grew to love Zilly and know what that support can make a difference for them. So they actually contacted Zilly's breeder, and they have their own Zilly now. The same name as Zilly. It's Zilly's cousin who lives back home. But these types of experiences and hearing these stories that are so powerful and make such an impact on a child's life is definitely important.
I hear that Zilly is very popular on Instagram.
Yes, Zilly does have an Instagram. Please follow her, Zilly the therapy dog.
Yeah, Zilly is great. The kids love Zilly. I have had on more than one occasion had to change the time of an appointment because the patient had an appointment with Zilly that conflicted, so we had to move some of their other appointments, but the kids love Zilly and talk about her all the time.
Absolutely. So let's talk a little bit more about referring a patient to the inn and how do they get there. I'm happy to talk about it myself, but if either of you have any experience on the clinical side of getting to the Children's Inn, I'd love to hear your input.
So I can talk a little bit about that. I would say most of our patients who are here for a repeat visit have already been to the NIH, know the Children's Inn, and will call the inn and set up their own visit to the inn even without us doing anything. I think, however, some of the kids who have never been to the NIH before don't know about the Children's Inn, and we can tell them about it and put them in contact with the Children's Inn. And this goes anywhere from really little kids, toddlers, all the way up to young adults. And I think the inn does a great job of accommodating and having activities for the littlest kids that we see up to kids that are making that sort of tricky transition from being a kid to a young adult.
So we actually house patients up to age 30. This number changed a couple years ago. It used to be age 26. But as you both are aware, working
30 is still a kid to us.
I was pushing that one.
Yeah.
Increasing the
Perfect.
age.
Well, I'm sure you could attest to it, but for our young adults that are 26 to 30, if they have a rare disease or a critical illness and have gone through treatment their whole life, by the time they're creeping up on the age where they're not able to go to the inn anymore, they want that support, they need that support. So increasing our age, and I'm happy to hear your thoughts on it as well, allow them to have that extra support as well.
Oh, absolutely. The Children's Inn allows our patients and the family members to connect with other people who just get it. When they go back home, people don't understand at all what they've been through. And it's not that they're here and they need to talk about their medications and the name of their disease. It's just knowing they're amongst other people whose lives are similar to their own, that they can't guarantee tomorrow, that every day is just really precious. And we really try to collaborate as closely as we can to be able to provide the best medical care that we can to support them therapeutically through our psychosocial support and research program and clinical interventions at the hospital. But then they come down here where they could be able to balance their life and just to be able to relax in an environment that feels as much like home as possible. We really found through our research that the people who've done the best are those who they accept their illness and they can be able to talk with other people about what their illness is, but they also have a life outside of their illness. And so a lot of the work is also helping them integrate back at home, back into school, back into work, or back into their activities that they once enjoyed beforehand. And you help them with that as well. You have grants that be able to help individuals who may want to be able to learn a new skill or take a class when they wouldn't ordinarily be able to do so. So it's a really beautiful collaboration.
Absolutely, perfect. So when we get those first visits to the Children's Inn, they walk in. The first time I actually came to the Children's Inn, my supervisor described it as the Walt Disney World of Maryland, and it certainly feels like that here. And so when children come in for their first time, they get that sense as well. When they first walk in, we have lit up mailboxes for thoughtful treasures that every day they come back from the clinical center, they are able to go to those mailboxes and pick out their goodie that they get. And so it's exciting, just the short walk from Building 10, the clinical center, down to here. They have something to look forward to. We offer field trips throughout the week. Similarly, we want them to have experience to look forward to as well. So those experiences range from things that they might not even be able to get back home. So horseback riding, sailing trips, other therapeutic activities and opportunities like Viz Arts, which is creating glass pieces, colored art.
It's very popular.
Yes. Absolutely.
I think one of the events that the Children's Inn has collaborated with us on is there are times when we'll have a number of kids that all have the same diagnosis that will all be seen at the clinical center and at the same time. And one of the comments that we always get is the kids are really enjoy getting to have social time with other kids with similar issues and not just seeing them at the clinical center when they're getting their CAT scan or something.
Yeah. And a population we really haven't talked about here is siblings. And it's so hard for the brothers and sisters who are back at home and don't really know what's going on here. And we know that a brother or sister who's really sick, it's pretty visible what's going on with them. That the pain that the sibling back at home may experience is invisible. So one of the programs that we collaborate with the Inn is Sibling Day. It's an all-day event where different members of the clinical center really open up their departments. For example, a laboratory of medicine. It's an entire room of labs, 5 different stations where they get to experiment under microscopes and be able to phlebotomy and to be able to learn about platelets and white counts and red blood cells with jelly beans. And, and then they get to a mock scanner, where they get to see what it's like to go through a scan and what that process is like, could be for their brother or sister. And then when it's available, we even have an operating room where they can be able to scrub in and to be able to have the experience of what it's like to be, how frightening it may be, but to be able to see what takes place in an operating room. And then we come down here and we have activities. We have a cardiologist who does a really fun event of a lunch, some subs. We have therapeutic art. We have therapeutic music. We have therapeutic games. And at the end of the day, my favorite part is that they come in and there's a standing ovation for them. From members of the healthcare team, from their families who surprise them to be there. And each person gets up, stands up, and gets an award for being a super sib. And the applause of being who they are, for being the sibling that is such an important part of the family is fabulous. My true favorite part is all you can eat ice cream that takes place every day.
That's everybody's favorite. The Sibling Day seems to fall at the perfect time every single year. Every time we start advertising it to caregivers always say, oh, that's amazing. The focus is always so much on the patient, that this gives a focus on a sibling and allows them to truly understand what their sibling is going through.
So we stop the video there as there's a foreword or an introduction to aspects beyond treatment. And now we follow up with the lecture, right? Excuse me. And in the lecture, now continuing with the lecture, on this page we have how common is cancer in children and adolescents. What is the prognosis for children and adolescents with cancer? What are the possible causes of cancer in children and adolescents? What does a child's cancer diagnosis mean for cancer risk in the rest of the family? How do cancers in adolescents and young adults differ from those in younger children? Where do children and adolescents with cancer get treated? If my child is treated at a center, a children's cancer center, will they automatically be part of a clinical trial? So these are questions that any parent would ask. Can children and adolescents be treated at the National Institute of Health? And what should survivors of childhood and adolescent cancers consider after their complete treatment? So how common is cancer in children and adolescents? Right, so we deal with that topic. While although cancer in children and adolescents is rare, it is the leading cause of death by disease after infancy among children in the United States. It's one. It is estimated that in 2024, a total of 14,910 children and adolescents ages 0 to 19 will be diagnosed with cancer, and about 1,590 would die of the disease in the United States. So these statistics keep changing each time. So among children aged 0 to 14, and we pray that the statistics will show a decline in the number of cases. That's what we need. It is estimated that 96 to 20 will be diagnosed with cancer, and 1,040 would die of the disease. And among adolescents aged 15 to 19, it is estimated that 50 to 190 would be diagnosed with cancer, and 550 would die of the disease. In the United States, the most common types of cancer diagnosed in 2016 to 2020 among children and adolescents were leukemias, malignant brain and other central nervous system tumors, lymphomas, epithelial neoplasms, and melanomas, soft tissue tumors, malignant germ cell tumors, and bone tumors. The most common types of cancer among children and adolescents differ by age group. For example, leukemias were common in those ages 1 to 4 than other age groups, and lymphomas were common in those ages 15 to 19 than in other ages. And for most common types of cancer among children and adolescents differed by age group. For example, leukemias were more common in the ages of 1 to 4, and lymphomas were more common in ages 15 to 19. And rates of the most common types of childhood and adolescent cancer differed by race and ethnicity. For example, in 2017, 22, 21, the incidence rate of leukemia was about twice as high in Hispanic and American Indians and Alaskan Native children and adolescents as in black children and adolescents. During the same time period, the rates of brain and other nervous system tumors were higher in white and American Indian, Alaskan Native children and adolescents than those of all other racial and ethnic groups. So as of Jan 1, 2020, the most recent date for which data exists, approximated 495,739 survivors of childhood and adolescent sac cancer diagnosed at ages 0 to 19 were estimated to be alive in the United States. We have checked the world statistics for other countries as well. And we pray that the number of cases come down each year. And good treatment is there, and effective yet less painful treatment is available. The next question, what is the prognosis for children and adolescents with cancer? The overall outlook for children and adolescents with cancer has improved greatly over the last half century, which is something very great, very commendable. In the mid-1970s, 58% of children ages 0 to 14 and 68% of adolescents ages 15 and 19 diagnosed with cancer survived at least 5 years. In 2013 to 2019, 5-year survival was 83.2% for children younger than 1 year and 87.8% for children ages 1 to 4 years, 85.7% for children ages 5 to 9 years, 85.5% for children ages 10 to 14 years, and 87.3% for adolescents ages 15 to 9 years. Although the 5-year survival rates for most childhood cancers have improved, recent decades, the improvement has especially been dramatic for a few cancers, particularly acute lymphoblastic leukemia, ALL, the most common childhood cancer. Improved treatments for ALL introduced beginning in the 1960s and 1970s raised the 5-year survival rate for children diagnosed with this disease from 57% and 75 to 92.3% in 2014 to 2020. The 5-year survival rate for children diagnosed with non-Hodgkin lymphoma also increased dramatically from 43% in 75 to 91.4% in 2014 to 2020. Now, in contrast, survival rates remain poor for some cancer types, for some age groups, and for some cancers within a site. For example, half of children with diffuse intrinsic pontine glioma, a rare type of brain tumor, survive less than 1 year from diagnosis, and only 10% survive 2 years from diagnosis. For soft tissue sarcomas, 5-year survival rates in 2013 to 2019 among children and adolescents younger than 20 years ranged from 65.1% for those diagnosed with Rhabdomyosarcoma to 80.8% for those diagnosed with fibrosarcoma or peripheral nerve sheath tumors. In 2013 to 2019, the 5-year survival rate for lymphoid leukemias, mostly acute lymphoblastic leukemia, was 96%, 94%, 86% for children ages 1 to 4, 5 to 9, and 10 to 14, respectively, compared with 61% for children younger than 1 year and 78% for adolescents. In 2013 to 2019, the 5-year survival rate for Ewing sarcoma was greater than 80% for children ages 1 to 14, compared with 69% for adolescents. And going to the further aspects of all the studies, the cancer mortality rate, the number of deaths due to cancer per 100,000 people per year among children and adolescents younger than 20 years declined by more than 50% from 1975 to 22. It dropped from 5.1%, it's about 100,000 children, and adolescents in 75 to 2.2 per 100,000 children and adolescents in 2022. Now, what are the possible causes of cancer in children and adolescents? We can know that most cancers in children, like those in adults, have alterations, changes, mutations, or variants in genes that lead to uncontrolled cell growth and eventually cancer. Some genetic changes that are passed from parents to their children, known as germline variants, are associated with an increased risk of cancer. Genetic changes that lead to cancer can also occur spontaneously in cells during development. Inherited genetic changes. About 8% to 10% of all cancers in children overall are caused by inherited pathogenic variant. That's a harmful alteration in a cancer predisposition gene, although the percentage varies across cancer types of 7 to 9. For example, about 45% of children with retinoblastoma, a cancer of the eye that develops mainly in children, inherited a pathogenic variant and a gene called RB1 from a parent. Children who inherit variants associated with certain familial syndromes such as Leaf-Romani syndrome, Beckwith-Wheatman syndrome, Fanconi anemia, Noonan syndrome, and von Hippel-Lindau syndrome also have increased risk of childhood cancers. Genetic changes early in development. Rare genetic changes that arise during development of one of the germ cells, sperm or egg, that unite to form the zygote and becomes a child can increase the risk of cancer in that child. Genetic changes can include broken, missing, rearranged, or extra chromosome, as well as gene variants. One such alteration is trisomy 21, or the presence of an extra copy of chromosome 21, which causes Down syndrome. Children with Down syndrome are 10 to 20 times more likely to develop leukemia than children without Down syndrome. However, only a small portion of childhood leukemia cases are linked to Down syndrome. Environmental exposures. Genetic changes that may cause cancer also occur in different cells of the body after birth, as the body is actively growing and developing during early childhood. The extent to which these changes reflect environmental exposures is unclear. Certain substances in the environment, such as cigarette smoke, asbestos, ultraviolet UV radiation from the sun, are known to be cause genetic changes that can lead to cancer. However, environmental causes of childhood cancer have been particularly difficult to identify, partly because cancer in children is rare and partly because it is difficult to determine what children might have been exposed to early in the development. Nevertheless, several environmental exposures have been linked to childhood or adolescent cancer. Example, one study found that melanoma in children and adolescents aged 11 to 20 years has many genomic similarities to melanoma that occurs in adults, including an enrichment of UV-induced mutations. 13, ionizing radiation can lead to the development of leukemia and other cancers in children and adolescents. Children and adolescents who were exposed to radiation when the atomic bombs dropped in Japan during the Second World War had an elevated risk of leukemia, and children who were exposed to radiation from Chernobyl nuclear plant accident had an elevated risk of thyroid cancer. Exposure of parents to ionizing radiation is also a possible concern in terms of development of cancer in the future offspring. Children whose mothers had X-rays during pregnancy, that is, children who were exposed before birth or who were exposed after birth to diagnostic medical radiation from computed tomography CT scans, have been found to have a slight increase in the risk of leukemia and brain tumors and possibly other cancers. However, genomic analysis of children born to people exposed to radiation or Chernobyl indicates that this exposure did not lead to an increase in new genetic changes being passed from parent to child. Several other environmental exposures of parents have been associated with childhood cancer. For some types of childhood leukemia, particularly acute lymphoblastic leukemia, associations have been described for fathers, tobacco smoking, and for parental exposure to certain pesticides at their workplace. Studies of childhood brain tumors have suggested associations with maternal consumption of cured meats. That's an interesting point. Brain tumors have been suggested with maternal consumption of cured meats. Note that point and do some research on that. Factors associated with reduced risk of childhood cancer. Researchers have also identified factors that may be associated with reduced risk of childhood cancer. For example, maternal consumption of folate has been associated with reduced risk of both leukemia and brain tumors in children, and being breastfed and having been exposed to routine childhood infections are both associated with a lower risk of developing childhood leukemia. You need to note that as well. What does a child's cancer diagnosis mean for cancer risk and the rest of the family? First and second degree relatives of a child diagnosed with cancer may be at risk or at increased risk for developing cancer if there is already a family history of cancer. That is, if the child's cancer is likely due to an inherited genetic disorder. A clinician may advise as to whether a child or family members could benefit from genetic testing or referral to a medical geneticist or cancer genetic counselor for evaluation. How do cancers in adolescents and young adults differ from those in younger children? Well, cancer occurs more frequently in adolescents and young adults aged 15 to 39 years than in younger children, although incidence in this group is still much lower than in the older adults. According to the NCI Surveillance, Epidemiology and Results Csir program, each year in 2017 to 2021, there were 17.14 cancer diagnoses per 100,000 younger than 15 years, 74.9 cancer diagnoses per 100,000 adolescents adults ages 15 to 39 years, and 528.9 cancer diagnoses per 100,000 ages 40 to 64 years. These are all statistics. The most frequent cancers diagnosed in adolescents and young adults age are cancers which are common among adults and younger children, such as breast cancer, melanoma, and thyroid cancer. But certain cancers, such as testicular cancer, are more likely to be diagnosed among AYAs, that's adolescents and young adults, than among either younger children or adults. However, the incidence of specific cancer types varies widely across the adolescent and young adult age continuum. Where do children and adolescents with cancer get treated? Children and adolescents who have cancer are often treated at a children's cancer center, which is a hospital or a unit within a hospital that specializes in diagnosis and treating patients through 20 years of age. The health professionals at these centers have specific training and expertise to provide a comprehensive care for children and adolescents with cancer and their families. Children's cancer centers also participate in clinical trials. The improvements in survival for children with cancer that have occurred over the past half a century have been achieved because of treatment advances that were studied and then proven to be effective in clinical trials. And about 90% of children and adolescents who are diagnosed with cancer each year in the U.S. are cared for at a children's cancer center that is affiliated with the NCI, Supported Children's Oncology Group. COG is the world's largest organization that performs clinical research to improve the care and treatment of children and adolescents with cancer. Each year, approximately 4,000 children who are diagnosed with cancer enroll in a COG-sponsored clinical trial. COG trials are sometimes open to older individuals when the type of cancer being studied is one that occurs in children, adolescents, and young adults. Children's cancer centers that participate in COG must meet and maintain strict standards of excellence for childhood cancer care. I repeat, for excellence for childhood cancer care. I misread that, right? Now, a directory of COG locations is available on the website. Families can ask the pediatrician or family doctor for a referral to a children's cancer center. Families and health professionals can call NCI's Cancer Information Center at 1-800-4-CANCER or 1-800-422-6237 to learn more about children's cancer centers that belong to COG in the United States and relate. Similar numbers available in the Indian subcontinent too, but on different codes and different centers like the RCC, etc. So the next question is, if my child is treated at a children's cancer center, will they automatically be part of a clinical trial? No, participation in a clinical trial is voluntary, and it is up to each family in collaboration with their treatment team to decide if clinical trial participation is right for their child. Can children and adolescents who have cancer be treated at the National Institute of Health Clinical Center? Children and adolescents with cancer may be eligible to be treated in clinical trials at the NIH Clinical Center in Bethesda, Maryland, because the NIH Clinical Center is a research hospital. Only patients who have a specific type or stage of cancer that is under study can be accepted for treatment. In some cases, patients with conditions that are rare or difficult to diagnose may also be accepted for treatment at the NIH Clinical Center. All patients who are treated at the NIH Clinical Center must be referred by a physician. NCI's Pediatric Oncology Branch conducts clinical trials at the NIH Clinical Center for children, adolescents, and young adults with a wide variety of cancers. Patients with newly diagnosed cancer, as well as patients whose cancers have come back after treatment, may be eligible to participate in a clinical trial. Physicians at the Pediatric Oncology Branch can also provide a second opinion on a patient's diagnosis or treatment plan. To refer a patient to the Pediatric Oncology Branch, the patient's health care provider should call 1240-760-403 local or 1-833-248-0479 toll-free weekdays between 8:30 a.m. to 5 p.m. Eastern Time. Parents can also call these numbers to learn if their child is eligible to participate in a clinical trial. NCI's clinical genetics branch conducts long-term observational and clinical studies of genetic susceptibility to cancer, mostly in families with a known or suspected cancer predisposition syndrome or families that have a higher than expected rate of cancer. Although some of these studies, participants, including children and adolescents, are seen at the NIH Clinical Center, the genetic susceptibility studies do not evaluate treatment or other interventions as a clinical trial. Information about active studies that enroll children and adolescents can be obtained by contacting the referral nurse at 1-800-518-8474. What should survivors of childhood and adolescent cancer consider after they complete treatment? Well, on this question, some people who have had cancer during childhood or adolescence may need follow-up care and enhanced medical surveillance as they continue to get older because of the risk of complications related to the disease or its treatment that can last for or arise many years after they complete treatment for their cancer. Health problems that develop months or years after treatment has ended are known as late effects. The specific late effects that a person who was treated for cancer might experience depend on the type and location of the cancer, on the type of treatment they received, and the patient related factors such as age and diagnosis. Additionally, some people with a history of childhood cancer may need additional follow-up if an inherited genetic alteration is found to be the cause of the cancer. Children and adolescents who were treated for bone cancer, brain tumors, or Hodgkin lymphoma, or who received radiation to their chest, abdomen, or pelvis have the highest risk of serious late effects from cancer treatment, including second cancers, joint replacement, hearing loss, and congestive heart failure. Long-term follow-up analysis of a cohort of survivors of childhood cancer treated between 1970 and 86 has shown that these survivors remain at risk of complications and premature death as they age, with more than half of them having experienced a severe or disabling complication, or even death by the time they reach age 50 years. Children and adolescents treated more in recent decades may have lower risk of late effects due to modifications in treatment regimens to reduce exposure to radiotherapy and chemotherapy, increased efforts to detect late effects, and improvements in medical care for late effects. It is important for people who had cancer during childhood or adolescence to have regular medical follow-up examinations so any health problems can be identified and treated as soon as possible. The Children's Oncology Group, COG, has developed long-term follow-up guidelines It's also important to keep a record of these details of the cancer diagnosis and the treatment that was received. This record should include the type and stage of cancer, date of cancer diagnosis, and dates of any relapses, genetic testing for inherited variants and somatic tumor variants, types and dates of imaging tests, contact information with the hospitals and doctors who provided treatment, names and total doses of all chemotherapy drugs used in treatment, parts of the body that were treated with radiation and total doses of radiation that were given, types and dates of all surgeries, any other cancer treatments received, any serious complications that involved during treatment and how those complications were treated, the date that cancer treatment was completed. And the record should be kept in a safe place, and copies of records should be given to all doctors involved, other healthcare providers who are involved with the child's follow-up care. Now, just about winding up on that part, the various cancer centers have programs to help patients and families navigate long-term survivor care, including both the physical and emotional issues that they may face after treatment. Many children's care centers have clinics where survivors of childhood care can go for follow-up care until they reach the early 20s. Cancer centers are now treating clinics dedicated to follow-up care for long-term cancer survivors of pediatric and adolescent cancers. Programs focused on adolescents, young adults, cancer survivors, and some of the more unique needs of these patients, including discussing and preserving future fertility, peer support, psychological support that addresses personal issues such as finances, education, occupational impacts, and transition to independence. Now we continue with the video that we stopped before starting the lecture, right?
Lunch and dinner throughout the week. We offer grocery gift cards for families to go grocery shopping, especially when people have dietary restrictions. We want them to be able to pick out their own foods. We offer educational support if people need funding for an activity or programs. We have support that way. We are always open to hearing how we can support our families and make sure that this experience for them is as seamless and easy so they can prioritize spending time with their child or young adult who is here for treatment.
Something that we discovered on this trip that's been helpful is my daughter just first year college, and a huge stress for her is how do I balance my schooling, and she does not like to sit in a room and do her homework, and because she needs a little outside noise distraction. So the last 2 days she has sat up in the little bistro area, and has done her homework, and it feels like her college experience. So she's getting schooling done as well, which she wouldn't do that in a hotel because she'd be isolated in a little room. And that, I didn't think about that until she brought that up. She goes, Mom, I'm so glad I have this, or I wouldn't get any homework done at all. And that's important to have that. So little unexpected blessing of having a setting that welcomes that support.
Yeah, I think the family kind of atmosphere at the end really, kids talk about that, parents just talk about that.
And the food.
Okay.
And Georgetown cupcakes.
Yes, Georgetown cupcakes. Actually, that brings up a good point. Our most popular event is bingo. If you are ever here, I think it's the second and fourth Tuesday of every month we do a bingo. We have a wide range of activities, those recreational programs that I told you about, but even educational, bouncing off what you said. We know people are here for extended periods of time, and Priya just started college, and she's able to do homework, and some people who are here who are missing school, we offer tutoring for them. We offer, if they don't speak English, we offer English lessons for them. We've recently started a STEAM program, so science, technology, education, or engineering, art, and technology. We want students and children to be able to feel like they can grow while they're here and have those hands-on experiences. Again, not to prioritize their time at the clinical center, but to be able to, feel like a child and grow here as well.
And we have a school at the clinical center for our patients, and unfortunately the school can't teach the siblings, and the children's end can, and that's such a gift for them and for their family members.
Okay, wonderful. Before we move on to our live questions, which please continue commenting below, we wanted to talk more with Dr. Glad. So this summer, we heard from the National Cancer Institute about the Childhood Cancer Data Initiative. So Dr. Glad, can you talk a little bit more about that?
Sure. So the Childhood Cancer Data Initiative is a program that will help to improve the treatment of children and young adults with cancer by allowing for data from different sources to be localized and used by different researchers. So there are lots of very talented people who are working on trying to improve the treatment of kids with cancer, and making a place where data generated by all of these different institutions and researchers is available for everyone to look at and to use is very important. I think this data initiative will be also very important for psychosocial data and allowing data from psychosocial research to be pooled and shared.
We are now going to turn to some live questions from the viewers. Okay, so our first question, we mentioned that the Children's Inn goes up to age 30. So what's it like for older teens and young adults there? Tracy, if you want to add on to this, feel free to.
My daughter turns into a child coming back here. She's 18 and she gets giddy. She was giddy because I'm playing in the little chairs and stuff. And we went out and watched the mascots on. We got in on Tuesday and they had mascots. And so even though they're older, there's that comfort of being like a child. And even the mailbox, she got a little note in there yesterday and it made her day. Even though she's older, she's a young adult. There's still plenty, and I think it's important because she's still my little girl, and she got to be that. But one of the families we met, it's dad that's coming here for the treatment, and they're staying here, and it's their daughter and wife is here as well, and so it just the whole family thing. I don't think that there's plenty for young adults and adults to do here. Even escape and get away, go have a cup of coffee or sit outside and just get fresh air.
Many of our young adults enjoy the young adult night out, which is no families with them. They just get to go out to a restaurant and it's just with other people their age. And I think it's 18 to 28 or 29.
Yeah, so our young adult night out, we have twice a month, and that ranges from different activities. We've gone to a paint and sip, fruit juice of course, bowling, we've gone to restaurants, especially with the nicer weather. They love being able to eat outside. It allows our young adults to be able to meet each other and connect, and although they're from all over the world with different diagnoses, they're able to connect with each other. With languages, exactly. They're able to connect with each other and feel like they're not as isolated and alone here. At the Children's Inn itself, we have a teen and young adult lounge, which is a huge hotspot for our teens and young adults, that they're able to go in. We recently got a smart TV in there, so they're always watching their Netflix or Hulu on there. But it's just a nice getaway that they are able to have their own space.
Yeah, I think it's really important even for people up to age of 30. If you think about when you start really establishing your life and your relationships, that happens in between the age of 18 and 30. And so if you have a serious illness, that really causes problems and causes more difficulties because you don't participate in the normal young adult activities. You're not getting your first job. You're not going away to school, some of our kids. And I think the ability for young adults with similar issues to be together and discuss things together really makes a huge impact.
Being alone in a hotel room when you're not feeling well is not hard. It's hard.
Absolutely. All right, we'll move on to our next question. Are there any stories you can tell or tell us more about why you do what you do?
That's a hard one.
Can we talk about medical?
Yeah, I think it's hard to trace back to figure out why you do what you do. I think thinking about why I continue to do what I do as opposed to getting another job somewhere else is that I think there's a couple things that are really great about working with patients here at the NIH. I think patients and their families are so inspirational. Not only are they going through something very tough themselves, but you're being very philanthropic, and the things that you're doing are helping a lot of other people, and that's, I think, really important.
Something that Tracy and I connected on their first visit here. So I got into this field. I got diagnosed with a rare disease when I turned 21, and when I met
over to me because he needs them to be able to swallow. I'm going to be there to support you. They don't get it. They don't understand what you're going through. They can't see what's happening on those floors. And to have somebody who could be there, and for me, just the honor of being able to be by somebody's side, whether it's for a new diagnosis or an end of life, or if it was to help because they don't have a meal that they just need to be able to find. Just being there for the good days, the bad days, and just taking that that journey is a tremendous gift. So we thank you and families like yourself that allow us to be able to be part of your family, to be part of your lives, and hopefully to help you grow through this and beyond.
Wonderful. So we'll head into our next question. What are some myths that you think people believe about the psychosocial parts of cancer care? A good question.
That's a great question. Every cancer patient is depressed. That, they can't think of anything but the cancer. That mental health care is stigmatizing, is only for people who are crazy. Not recognizing that we all need support and help and guidance from people who've been there and done that and can help them grow.